Welcome to this module on treatment planning for implant dentistry. And when you think about it, treatment planning for implants and grafting is really the most important step in the entire process of replacing a patient's missing teeth with dental implants. What I'd like to do is really go over the protocol that I utilize when a patient comes in my office, the thought processes that are involved to treat and plan both large and small cases. And I hope you enjoy this presentation, and I think you're going to get a lot out of it. Scott Gans says, patients come to the dentist to have teeth, not implants. And I like this statement, because unless you really explain to the patient what's possible and what's available, they're not going to be able to make decisions. And really what you need to do is treat and plan with the patient what the end result should be. And what we're doing is coming from the end result when we treat and plan. And that's probably the most important point, and probably the most important thing that I do when I sit with a patient and treat and plan implants. I want to know what they want. And how do they know what they want unless I explain to them what's available? What can they afford? It's been said that implant dentistry is a prosthetically driven discipline with a surgical component. And as with anything in life, if you begin with the end in mind, you're going to figure out how to get there. In my bone grafting module on putties, I show you that you can't let the patient's bone level dictate where the implants are going to be. So if you could place the implants in the correct position with regards to forces, occlusion, and aesthetics, that's what you want to do. And that's what we can do with the bone grafting that's available. Natalie Wong, who's a prosthodontist up in Toronto, says that dental implant therapy requires a careful patient evaluation, surgical planning, and meticulous prosthetic execution. That's another great quote. There's a lot involved with treatment planning. And if you follow the different steps that I'm recommending and that others have recommended, you will have success. I am going to be showing a bunch of cases and clinical aspects of treatment planning, but I kind of want to start off with some philosophy and background on treatment planning before we get into that. In this country, according to the ADA Survey Center, oral surgeons and periodontists are placing most of the implants on patients in the US. While when you look at some of these general dental journals, you can see that more and more dentists, general dentists, are getting into implant placement. But mostly oral surgeons right now and periodontists are placing them. This article by Christensen and Jada says the people that are ultimately responsible for the long-term restorative follow-up on patients with implants are general dentists and prosthodontists, because it's a prosthetically driven discipline. And I like to say that either the surgical dentist and or the prosthetic dentist must have an understanding of the consequences of the forces on the implant and the occlusal relationship that translates those forces. And then you must translate that to an aesthetically ideal prosthesis. So basically, there has to be good communication between all of the team members on an implant team. In my practice, I do the surgery and the prosthetics, unless I'm being referred a patient. So that team, is a lot tighter than having a surgeon that you don't really talk to that often. So I'm an advocate of good communication between the surgeon and the prosthetic dentist. And that's what has to be for success to happen in implant dentistry. So more and more we see implants being advocated in general practice. And with all the recent technologies on the market, there's a lot of good going on. And the success rate of implants is so high if it's done well, if it's treat and planned well. And that's why we're here today, and this is the key to it all. There's lots of factors to consider when placing implants. And this is all part of treatment planning. You have to have a good overall view and understanding as to what's happening and be able to put it all together into a team approach and implement it. So let me just start off by just showing you basically implant placement 101. We're talking about placing, in this situation here, 2 implants to replace 2 missing teeth. But what's involved to treat and plan this? What kind of occlusions involved? Was there any soft tissue or hard tissue considerations involved? How was the case planned financially with the patient? So many thoughts, so many things to think about in order to have these 2 implants support 2 teeth. Are they going to be splinted? You know, it's really endless. And once you start doing this, after a while you get into a routine, and when you treat and plan, for example, these 2 implants, you have a protocol, and then everything kind of falls into place. So I just want you to see basically what we're talking about. We're talking about putting 2 titanium fixtures into the patient's bone in order to support a prosthetic end result. And then when we talk about full arch cases, how do you know whether it's going to be a fixed case or a removable case? And that's all part of treatment planning. Treatment planning implant dentistry is a very comprehensive process. So when you look at a case like this, and the patient presents with missing teeth on the upper arch here and on the mandible, which teeth are you going to save? Can this patient handle a year of grafting, implants, and all these procedures and all the protocols involved? How are you going to provisionalize the case? So these are questions I ask myself, and I'll review some of these cases in this lecture. What about a case like this, when the bridge is basically coming out of my hands because it's being supported by 2 teeth here that have posts in them. There's no posterior occlusion to speak of, and all the forces now have been placed on this long span bridge with 4 ponics. And now, where are we going to go from here? What is the bite relationship? How are you going to provisionalize this case? And I'll show you this case later. How do you time the treatments of the grafts, doing the perio? Is this going to be a removable or a fixed case? So these are the kind of things that I think about when I'm treatment planning a case like this for implant dentistry. This is from an article that I've written for the Academy of General Dentistry for their journal. And basically, I've broken up treatment planning for implant dentistry into 5 steps. The first step is to assess the patient and the health history. Really see what we have here. Assess everything. The second step is to educate the patient about what is available and the different alternatives that are available. And I'll review each one of these in a minute. The third step is to chart the mouth and do radiographic imaging, basically gather data. The fourth step is to treat and plan for different areas of the mouth and the different prosthetic options that are available in those areas of the mouth. The fifth step is planning for the prosthesis, and then actually implementing the treatment sequence and how to provisionalize the case. So if you do these 5 steps, you will have a comprehensive plan to deliver good implant dentistry to replace missing teeth. So let's start with the first step, and that is assessing the patient and the health history. Well, you certainly want to take a good medical history on a patient in general, and certainly a patient that needs dental implants. And the more comprehensive that medical history can be, the better. It involves charting the mouth, looking at the prognosis of teeth. That's certainly important because you don't want to base a case on teeth that aren't going to be there in a few years. Charting the existing restorations, looking at the amount of keratinized tissue and the quality of the soft tissue, doing 6-point probings, getting bleeding points. And it's important to get this information, especially with respect to the tissue response when you extract teeth, to predict how the papillae is going to respond, especially when we're talking about teeth in the anterior region. My module on aesthetic implant dentistry will cover that in much more detail. You want to see what drugs the patient is on. For instance, if the patient is on a bisphosphonate drug, that will probably require a separate informed consent form because of the possibility of osteonecrosis, and probably a conversation with the patient's physician. This is the pharmacological protocol that I utilize for any kind of implants or grafting in my office. We have the patient on Decadron. We have them on an antibiotic. We have them on ibuprofen 1 hour before the appointment. And then we have them on Paradex and Lortab. And this is what I do for all my procedures. The reason I have them on the Decadron as well as the ibuprofen is they kind of work synergistically together, and they stop swelling and pain. So this is just the reason why I do this. And pretty much I like to have a good reason for anything I do, not just because someone told me so, and this explains that. When you're looking at the medical condition of a patient prior to implant or during implant treatment planning, basically the only contraindications is any uncontrollable disease, uncontrollable psychological problems, any uncontrolled drug or alcoholic intake, and pregnancy, of course. Considerations are smoking, past radiation. So anything that's uncontrolled is going to require a conversation with the patient's physician. We do a comprehensive exam in my office, including the bell scope exam for cancer screening. Just related to medical history and treatment planning, really, I utilize conscious sedation, both oral and IV, in my office. And it's important when you're utilizing these modalities to understand what type of medical ASA classification they are. When we do sedation, we do an EKG, we monitor CO2, blood pressure, digital pulse, and pulse. So it really brings in your medical training when you start doing this. One advantage to the IV sedation, and I use Versed mostly, is that we have a line in, and we have the immediate availability to dispense any kind of reversal agents or any drugs that might be needed. It's very easy to get certified by, I think the docs course will get you certified in a few days to use Halcyon, but you certainly should have at least the oral sedation in your bag of tricks to help relax patients. We have drills in my office with a Manigan. We record those drills from a medical legal standpoint. And this is all part of treatment planning, and I'm just kind of sharing with you. And in that drill, we have a SOP for dental emergencies, and I certainly would recommend every practitioner to have a standard operating procedure for emergencies in their office written down and rehearsed. And we do this, and we log it, and I think it's good medical legal protection, and it's good so that if an incident does occur, we're available. This is my crash bag, and in the crash bag, of course, we have an AED and all kinds of oxygen equipment to get the patient some oxygen in their bodies. And part of treatment planning also, when we're talking about medical histories, is informed consent forms. Very important. On my website, tischlerdental.com, there are some of the informed consent forms that I use available for you to share. In our office, we are paperless, just sharing that with you, and we have the patients signing e-pads and going over all the different informed consent forms for the various procedures that we do. So that's why it's important to assess the patient, have a good health history, understand the medical responsibilities as an implant dentist for doing this surgical procedure. The next thing I want to talk about is educating the patient about what's available and the alternatives. I'm sorry, I'm continuing with assessment. So we'll get to educating in a minute, but we're still talking about assessing the patient and the health history. And so not only the medical history are we evaluating, but we're also evaluating the patient's arch form, the bite relationship, obviously, and what kind of possible parafunctional activities they have. Looking at the TMJ. And the reason we're doing this, and the reason we're looking at the bite and the forces, is because if you have too much stress on an implant, then the implant's going to fail or have bone loss around it. We're trying to avoid that. And if you look at this formula, that stress equals force over area, we're trying to decrease the stress by increasing the area of the implant, or the implants, because the forces are a lot harder to control. What we can control is the area, which means how many implants, how long are the implants, how wide are the implants, and how are they coated. And we'll talk about that in a minute. Because if you have a larger area, you'll have less stress. And this formula doesn't lie. So we need to increase the area to decrease the stress. There are three types of forces. You have compressive force, which is basically a force that goes straight up and down. And We don't have that in the mouth too often because we're chewing and the teeth are going every which way with all the muscles in the mouth. So often other forces such as shear force, which bone is the weakest in, is applied to an implant. And you could see from this photoelastic model that a lot of the stress on implants comes at this crestal area here at the top. Bone, and I think it's important to understand a little bit about bone, bone wants to be in a homeostatic mechanism where there's not too much stress or not too little stress. And that's why if a tooth is removed, then oftentimes in the literature it shows we're going to lose bone because we're lacking a piezoelectric effect on that area. So bone wants to be in this adapted window here. And if it's not, and there's other reasons for this, you're going to get bone loss and cupping here at this crestal module area. And there's a multitude of factors which could cause this. There's really 3 of them according to the literature. It could be because of the occlusion. It could be because of the microgap where the abutment meets the implant. Or it could be a reformation of the biological width. And according to some of these articles, this one by Mish and Homlei Wang, there's those 3 factors, but really occlusion seems to be the driving factor mostly. And I think if the occlusion is done correctly, meaning there's not too much stress on an implant, and there's ways to do that, which I'll talk about in a minute, you're going to get less of a chance to have this bone loss at that gap. So there are different factors when treatment planning. We want to look at the bone density. When there's less dense bone, we're going to put more implants in. We want to look at the surface area of the implants. And basically what we're doing, we want to talk about treatment planning from the prosthetics considering the forces on the implants. And there's different ways to increase the area. We could, as I said, increase the number, the length, or the width. But if you look at it, at this literature, 3 implants instead of 2 can decrease the moment torque by 1/2, and the bone forces by 2/3. When you're talking about the length, when you have soft bone like D4 bone, you want to have longer implants for a better initial fixation and early loading. And that's because when an implant's placed in the bone is healing at different rates. So the more surface area you have by increasing the length, you have a better chance of there being mature bone in more than one area. And then we can always increase the width because every 0.5 millimeter increase in width gives a 10 to 15% increase in the surface area. And as I showed you, the greatest stresses are at the crest. So width in some ways is more significant than the length. So looking at this formula one more time, and we will over and over again because this formula is what drives success in implant dentistry. You want to look at force factors. You want to look at power function. You want to look at the position of the abutment teeth, the nature of the opposing arch. If a patient has a denture, there's a lot less stress than if they have natural teeth or implants. The direction of the load forces. You certainly want to look at the crown to implant ratio. And I'm going to come back to this in a minute because this really falls into treatment planning and the bone level and whether or not we're going to graft bone to get a better crown to implant ratio. So think about this in a minute. We also want to look at the masticatory dynamics. So when a patient comes in and he's a dentulous like this in the posterior mandible, and you look in his mouth and you see all this, obviously symptoms of a strong bite, possibly some GRD, but you certainly don't want to under-engineer a case like this that has bruxism and a strong bite. When you have a normal bite force, it's between 5 and 200 psi. When you have power functional activity, you can be in excess of 1,000 psi. So that's quite a big difference. And the duration is longer for that. So here's how that patient appeared with broken down teeth. And a lot of the failures in implant dentistry occur because of bruxism and power functional activities. The forces can be decreased by the magnitude, the duration, the type of force it is, the direction, and other factors. So let's control what we can control, and that's really the surface area, though. So you could look at the parafunctional activity of the patient. You could look at the crown height, the musculature of a patient, the mascatory muscles. If a patient's a very strong, let's say a linebacker, they're going to have more muscle activity than an elderly female, obviously. You want to look at the position within the arch. The forces are greater further back in the jaw, the direction of the load, and then once again the direction of the opposing arch. There are different types of parafunctional activities: bruxism, clenching, and tongue thrust. And there are 6 categories of parafunctional, or also called non-functional, tooth contact. You have local factors, you have systemic factors, you have psychological factors, occupational factors, and then there's involuntary factors, and then also voluntary factors. So these are the reasons that that a patient would have parafunctional activity. When you have occlusal overloading, you're going to get possibly and quite likely crestal bone loss on the implant, and then mobility. You need to diagnose it. What are the signs and symptoms of parafunction? Well, obviously excessive wear, increased mobility, cervical abfraction. That's not toothbrush abrasion. That's from micro movement around the cervical area by the gum. If you see deviation of the lower jaw opening, looking at the muscles, if you see increased size of the temporal and masseter muscles, that's a good sign that the patient's going to be in parafunction. Fractured teeth, uncemented crowns, and limited occlusal opening. So these are signs of parafunctional activities. So when you see this abfraction here, this is not toothbrush abrasion. And you have to also look at cantilevers, because if you have a crown that has a mesial distal cantilever because the implant was undersized, that is a form of stress, and you want to try to avoid that. It's a moment torque or moment force right there that's going to put stress on the implant and the implant parts. You want to look at the crown height under lateral forces, because this is a vertical cantilever. And when I get into the classification of the different types of bone in a minute, I think I'll really hit home with that and show you how that really comes into clinical reality. Dentists should know the vertical and horizontal dimensions of implant dentistry. And basically, you want to have enough height. You need at least 5 millimeters of height. Now, if you have too much height, obviously that's going to be a problem also. You certainly want to look at the opposing arch. And if you look at this, you want about 5 millimeters of height for the abutment, but you need 8 millimeters total because of the porcelain, because of the prosthetic platform. So these are just numbers and things you should look at when you're treatment planning to make sure you have enough height, because it may require some resection of the bone in order to gain this height if you need it. Once again, looking at the whole picture of the bone level and the implant and the crown to implant ratio. Pontics should be avoided when you're treatment planning, because the flexure of metal is related to the cube of the distance. So when you have 3 pontics, it's actually 27 times more stress than a 1 pontic restoration. So this is something you should know when you're treatment planning and understanding what's happening. Now, if you look at an X-ray like this certainly looks like occlusal overload. You have bone loss halfway down on this very thin implant, non-splinted. So you have 2 implants supporting an entire arch, and this is a recipe for failure. The literature also shows that angled implants create more stress than parallel implants. So this situation here, where you're placing an implant in the pterygoid area, not only is it a blind surgery, but it's also not good from a stress factor. the angle of the implants distribute occlusal loads best when the forces are in the axial direction. So you want to avoid angled implants if you can. Now, if you look at what's being touted in the advertisements in the journals, you see companies advocating 4 implants to support an entire arch, with 2 of them on an angle. So this kind of goes against the grain of what I'm saying, where you don't want to have angled implants if you could avoid them. And in my opinion, I think there could be some more engineering on some of these cases. And if you look at a case like this and a case like this, you can just tell that there's more support by having these implants that are more abundant. And it allows for a more natural-looking prosthesis. But companies are advocating it. This is an advertisement from a lab showing 4 non-splinted implants to support a full arch denture. Not what I do in my office. I think that there are better ways to address that. Here's an implant I found on the internet. Basically, it's just a very thin implant, very much under-engineered. And same thing here. It just doesn't make sense. And you can see bone loss already on this implant. And here too. So when you have an implant on an angle, it increases stress at this crestomodule area. So one of the first things you want to do when you're treatment planning is to create articulated study models and be able to see the bite relationship and do a face bow. And Frank Spear says the one thing that virtually all occlusal philosophies agree with today is even simultaneous tooth contacts on all the posterior teeth and canines in central closure. I think this is a good way to sum up occlusion for dental implants. When you design an occlusal scheme, many variables must be taken into consideration. And basically what you want to do is you want to incorporate axial loads and minimize lateral interferences, but very tough to do. You can't always have the patient biting straight up and down. You can use devices like the tech scan to measure biting forces, and you can see in this case that the implants load later. You can see it right there. And the reason that is because dental implants and teeth act differently in the mouth because they're different animals. A tooth has some apical movement, whereas an implant does not. Less movement laterally. There is a similar modulus of elasticity with teeth, whereas with implants, it's much greater than cortical bone. And this is the most important one, where signs of problems and stress with a tooth is pain and PDL widening, whereas with an implant, you're going to get bone loss and then mobility of the implant eventually. So now I'm ready to go to the second step, and that is educating the patient about what's available and the alternatives that are available. In my office, what I do is I will offer the patient models and different educational venues to see PowerPoints and really explain to them what's happening, what are we trying to do. And that's important. My website has educational materials on it. And my website also has educational materials. This is the player. And then there's different materials here for a patient to download to learn about implant dentistry. I do feel the models, if they can see something three-dimensionally and hold it, it certainly allows for better instruction to the patient. So that's what I do. I have different models in my office, and I educate patients with pamphlets. So education is quite important. The next thing I'll talk about now is charting the mouth and radiographic. So the next step is to chart the mouth and look at the radiographic imaging. And obviously, charting the mouth is quite important. You want to document the restorations the patient has, perio. You want to basically draw a very good record of what the patient has in their mouth. And this is from the Dentrix program. We chart on the computer in our office. And we also want to look at, obviously, radiographs. And, you know, although pantographs can offer some good information, a CT offers an abundant amount of information that just blows away any kind of two-dimensional imaging. And if you look at my CT module, you'll understand that these 4 images allow for ideal treatment planning for implant dentistry. We take records. Obviously, we're going to take study models. We're going to articulate them using a Facebook. And we're going to often create a CT template. And once again, in my CT module, I get into that more so you can understand what's involved with that. So you can see the tooth on the CAT scan and then treatment plan backwards from the prosthetic end result. Photos. These are the photos that Dr. Wang takes. And certainly, you can't take too many photos. And it's a good record. So we've assessed the patient. We've educated the patient about what's available. We've charted the mouth. We've taken radiographic images. The next thing we're going to look at is treatment planning for the different areas of the mouth for implants. And it's important to understand, really, the amount of bone you have to place an implant. It sounds silly, but it's quite important. And the bone quantity in an area where you're placing an implant is measured by the width of the bone, the buccolingual width, the height, the length of the bone, mesial distally, the angulation of the bone. And you also want to understand the density of the bone in the different areas of the mouth, because if you're in the anterior mandible, chances are you're going to be dealing with D1 or D2 bone, which is very strong, hard bone. And in the posterior maxilla, you're more than likely dealing with a very soft bone, D4 bone. In a Division A ridge, which is the MISH classification, you have abundant bone. You have bone that is greater than 5 millimeters in width. It's greater than 10 to 13 millimeters in height. There's 7 millimeters of bone there available, and there's not a lot of angulation, and there's a good crown to implant ratio. So that's abundant bone, and that's what you want to see. As you get into Division B bone, according to Mish's classification, there is less height, there's less length of bone available, there's more angulation. So all of a sudden now, we have a more compromised situation. And in a situation like this, where you don't have a lot of width, you may sometimes do osteoplasty to lower the bone, because as you lower bone, it gets wider in general. But think about it, what you're doing. When you lower the bone, you're increasing the crown to implant ratio, and that's not a good thing. So in a situation like this, you may opt to augment the bone to increase that. You may want to use narrow implants, but these are all somewhat compromises from what's ideal. When you have a Division C ridge, really unfavorable width, height, length, and angulation. And at that point, you could take more bone away, once again a compromise. You could augment and deal with any problems you have for aesthetic reasons and that type of thing. And then there are other alternative implants that are not being used that often in mainstream implant dentistry, but you can use a subperiosteal implant or even a transosteal implant, which is something that I certainly don't do myself. So bone can be augmented. I showed you that in my grafting module. And then obviously Division C bone is just severely deficient and limits your availability of prosthetic and surgical options. Because when you see a pencil-thin mandible like this, you have to be careful not to fracture that mandible on placement. Now, these are some of the questions that we're looking at. Is it going to be a fixed bridge or a removable prosthesis? What are the finances involved? What is the inter-arch space? What is the lifestyle of the patient? Can they tolerate a provisional for 9 to 12 months? Will they be compliant with hygiene? And how much lip support do they need? These are things you're going to kind of ask yourself. Carl Misch's textbook on dental implant prosthetics is certainly something I would recommend. It's a good overview and a good research book to have on implant dentistry. So I just want to review the different classifications that are available when you're talking about the alternatives for implant dentistry. If you're talking about a fixed prosthesis, we could be talking about an FP1, an FP2, or an FP3 prosthesis. And this is what this looks like. FP1 is basically an ideal situation where you have the bone up to here. When you have an FP3 situation, the bone is lost from a standpoint of height. And now look at the implant to crown ratio. It's so much greater. And not only do you have an implant to crown ratio issue, you also have now pink porcelain, and you have an aesthetic issue. So this is all part of treatment planning. So here's an FP1 with an ideal situation. Here's an FP3. So an FP3 situation are the high water bridges and situations that really aren't that ideal. I've been taught by Carl Misch, and I believe this, that we're much better off having a cement retain restoration that simulates a natural tooth as closely as possible. So the fixed prosthesis depends on the amount of soft and hard tissue that are being replaced. FP1 replaces only the crowns, looks like a natural tooth in size and contour. FP2 replaces the crown and the portion of the root. And the crown contour appears normal in the occlusal half, but it's elongated or hypercontoured in the gingival half, and that's what we have here. So much rather deal with an FP1 situation. It's much more natural, just like natural teeth. When you talk about an FP2 situation, that replaces the crown and a portion of the root. And it's not as natural looking, but if we can deal with an FP1 situation, it's much better off. But you can see in an FP2 situation, we obviously have elongated teeth and something that doesn't look as natural. When you get to an FP3 situation, this is really very unnatural. It does work, but it's not as ideal as an FP1 situation from an aesthetic standpoint and also from a hygiene standpoint. FP3. Now, one thing you may want to think about when you're treatment planning for implants in the mandible is that as the jaw opens, there's torque and torsion on the jaw. So that's why you'll never see me connect implants distal to the foramen bilaterally, because I want to allow for that torque. But if I can break it up anterior to the foramen, let's say for here, that's not going to happen, or you will reduce the likelihood of that happening. The advantages of a fixed prosthesis in general is that the fixed prosthesis is supported by the implants, and there's less stress. The final restoration in general is more similar to natural teeth, especially with an FP1 situation. And the literature shows that there's more longevity of the prosthesis when you have an FP1, 2, or 3 situation. The disadvantages to having fixed prosthetics with the implants is that there's more cost, they're more difficult to keep clean, they can't be removed and cleaned. The implant placement has to be more exacting to support the final prosthetic and aesthetic result. Aesthetic planning is much more critical because you don't have a flange to build lip support. So those are the thoughts you may want to think about when you're treatment planning for different areas of the mouth. Now, if you're planning, when you're talking about the fifth step and planning the treatment sequence and for visualization of the case, this is where we're putting it all together. And we're gathering information from the interviewing process, from the radiographic process, and the clinical data. So this is where the rubber meets the road here, and we're basically going to start looking at how do we tie it all together. So this is where all the treatment planning steps come together, and we bring it to clinical reality. So let's put it all together from the gathering information, interviewing, the radiographic information, and now the clinical data. And let's look at a couple of cases. So for example, a patient comes in, and we've interviewed the patient. We understand them. We understand their needs. They understand what's possible. Where do we begin? What is the very first step that we do? What are the clinical steps that we're going to take now? Well, by looking at this pan, you could see that the patient is obviously edentulous. There are some teeth that shouldn't be there. And there's obviously, if you look clinically, you can see there's wear on the teeth. So these are the kind of things that we're looking at when we look at a case. We know where we want to go. How are we going to get there? So this patient, for instance, presents with this collapsed bite. How are you going to sequence this? How are we going to sequence it? So what I would do in a case like this, I would extract number 3 and 5. I would open the bite with some lab processed metal reinforced temps. Patient does not want to wear a denture. I would go 6 to 11 with the temps with some cantilevers. I would do scaling and root planing. And then I would do implants on the upper right, upper left, and lower right. So once again, I would open the bite, provisionalize them, do the perio, place implants, and allow those to heal. So here's a case that presented. This gentleman presented with a pretty unsightly smile. And this is what he looked like clinically. He was edentulous in the upper right, edentulous in the lower left. So the first thing I'm going to do in a case like this is I'm going to provisionalize this case with some cantilevers here. You can see also did not want to wear a denture. And these are the lab processed metal reinforced provisionals on the maxilla and mandible. Here's how the provisionals looked. So right away we have a pretty substantial improvement in aesthetics. And I'll then go in, I'll place my implants. So I've ascertained the correct vertical dimension. Now I'm going to rebuild the edentulous areas with implants or the bone to place the implants in order to meet that vertical dimension and aesthetics. We did sinus grafting here. Now we're going to go back and prep the teeth and let the implants heal and restore everything together. And we're just going through the prosthetic steps. Make a second set of provisionals once I uncover the implants. And once again, on my simplifying implant dentistry module, you can see all these parts and sequence of events. And here's how the final case looked. So that's the general sequence I do, and that's how we look clinically. Another case, a patient came in with a fixed prosthesis that was failing in the anterior maxilla. And you could see she was missing her teeth in the posterior regions. And this bridge came out of my hands. It was basically on 2 teeth with posts in them. Not a big surprise there. You can see her bite was collapsed. So the first question I'm going to ask myself is, how do I provisionalize this case? How do we make temporaries here? Well, I basically do the same thing. I create lab processed provisionals that are metal reinforced. And here's the metal reinforcement. And this is only 4 or 5 teeth. And I do this quite a bit. You basically tell the patient to eat soft foods and be very careful. I then go back and I actually use some mini implants to help support this long span provisional here. But I place my implants, and then we uncover. We take our impressions. And sometimes I'll make new temps, sometimes I'll reline those temps. And that's the final metal try-in. So we went from there to there with implants. A little bit of pink porcelain here, but she has a very low lip line, so that's not a factor. Here's another case. Patient presented with this situation. Edentulous in the posterior maxilla on the right side and on the left side. And here's how she looked clinically. So the first thing I'm going to do is create metal reinforced provisionals. Here's the metal. These are the provisionals. I'm going to obtain a good bite relationship, better aesthetics without the lipstick on her temporaries. And then I'm going to take a CT and plan for my placement of implants. I'll now have the patient wearing the provisional for a period of about 4 months while the implants are healing. And I'll then uncover them, take impressions of the implants and the natural teeth. Soft tissue model, new provisionals, and then this is the final restoration. This is an interesting case where a patient presented with an old maxillary fixed bridge on about 5 teeth. And he knew it was time to do something, and he did not want to wear a denture. So what I chose to do in this case is to start off by making a lab process provisional, once again, place implants. Then I went back after about 3 months, and I actually used these implants to support another provisional and some of the natural teeth. And then I went back and placed more implants. So I segued the case. So here we had 5 implants, and then I added more, another 5 implants, and I kind of segued it. It takes longer to do this, but in the end, he has quite a substantial prosthesis and no teeth that are questionable. But he did not have to wear a denture the whole time. So you can segue these cases also, which is what I do. What do you do when a patient presents, in this situation, missing teeth in the anterior maxilla? Well, first thing I'm going to do, first I'm going to check the lip line with just some wax and make sure that the teeth can support it, and it did. I'm then going to make a lab process provisional. I'll use a few mini implants to help support it. And this is the radiographic template for a CT. And this is the provisional. And I'll plan the case for implants. Patient will wear the provisional during the time period of implant healing. And then I'll take my impressions. I don't mean to make it sound so simple, but if you follow the sequence, it really is. And if you look at my module on simplifying implant dentistry, you'll see how simple it is to take these impressions, and you'll understand all the different parts and pieces and sequence. One more case before I finish up. Long span bridge here that was failing. And I will then plan the case for implants. And I'll make a provisional. Patient will wear this provisional now for about 4 or 5 months. And then I uncover. I'll reline the provisional once I put the healing caps on. That's what I'm doing here. And then I will have a new provisional made and a metal try-in. And this, once again, is in my simplifying implant dentistry module under the sequence of what I do. Pick up the metal, which I talk about, and then we go to completion. One more case, another long span bridge that's failing. What a surprise, 5 ponics and the bridge is failing. The stress on this is immense. So I will once again create a lab process provisional, connecting all these teeth. I actually utilize 1 implant here to help support this long span area. And we ended up not using that implant on a permanent basis because it failed. But in the end, I got these other 4 implants in. I uncover. Reline my temp. And then do metal try-in. And this is the final bridge. I'm just showing you how I transition these cases. But it's the same basic sequence. Provisionalize, build up the bone, place the implants, let that heal, and then go back and restore it. So basically, when I am presented with a edentulous patient, I will go review the medical history, do an interview, like I said. I will do an examination on the TMJ health, bite relationship. I'll do my radiographs. I'll plan for provisionalization. Basically the same steps that I showed you, maybe in a little bit different order here. But then what I do, and this is from a clinical standpoint, practice management standpoint, is I present what's ideal. A fixed implant prosthesis, and that will take about 5 or 6 months without grafting, or 10 to 12 with grafting. And I give one fee for the entire case. And the fee is not really specific to the number of implants I'm going to place. It's basically for the job that's going to be done. And then I also base the fee on the aesthetic criteria and how difficult the case is. The next choice of treatment in this situation would be for an implant-supported bar openature. So I think you're getting a feeling now from this presentation today of my general flow of how I treat and plan and the sequences of treatment planning. And my website, under the For Dentist area, has a lot of information on this, and I welcome you to visit it and email me with any questions. And I hope you enjoyed this presentation.